Welcome back to another episode of the Resting Stitch Face podcast. I'm your co-host, Dr. Erin Sheffield, here with
Dr. Sarah Harding.
Welcome.
Welcome back for another episode. Today, we are joined by the beautiful Dr. Adrienne Towsen. She's a board-certified orthopedic surgeon turned entrepreneur and health optimization physician. After completing her orthopedic surgery residency at Allegheny General Hospital and a sports medicine fellowship at the Thomas Jefferson University, she spent 21 years practicing in Chester County, Pennsylvania. A single mother of 2 daughters, Adrienne built her surgical career while raising a family and later discovered a passion for competitive ballroom dancing. There you go. Which sparked a deeper interest in performance, recovery, and longevity. Following a private equity acquisition that transformed her practice environment, she made the bold decision to leave orthopedic surgery after more than 2 decades to reinvent her career, which we love. Today, she is the founder of Towsen Clinic, a health optimization and performance medicine practice in Westchester, Pennsylvania, serves as a clinical advisor in the peptide education space, and consults within the surgical technology industry. Through her work, Adrienne helps people optimize their health, performance, and quality of life while proving that it's never too late to begin again. I love that.
Yeah.
What a great bio. Wow.
Hello.
Hey.
So much I want to talk about already.
I know.
We're-
Well, welcome. We're so glad to have you here.
Thank you. I'm really glad to be here. This will be fun.
Yes. And this is so interesting, just the intersection of medicine and dentistry.
Yeah.
We're all surgeons here, right? And so we in dentistry talk a lot about this private equity takeover because we've seen it happen in medicine. We've seen it with hospitals. We've seen it all over the place. And it's happening in dentistry and people are just falling for it. You know, like it's like this wonderful thing.
Yeah. Don't fall for it.
Don't fall for it. Right. And so, but I understand, right? Because I do understand. And so I love that you are in this space and talking about it from the physician standpoint of lessons learned and miseries suffered.
Yeah, so you really pivoted. So you got bought out by private equity, which eventually forced you out of your chosen profession. So can you tell us a little more about that transition and what happened there?
Yeah, sure. I'd be happy to. So yeah, I was with a wonderful group that I loved for 19 years. So it was my second job out of fellowship. So yeah, so I my first job out of fellowship was 2004 to 2006, and I was hospital employed at just a little hospital. And then in 2006, I joined the practice that I left a year ago. So and it was a wonderful private practice in the community here in Westchester, Pennsylvania. So we're not that far from Philadelphia, and it was actually looking back on it now, especially like my dream job. I mean, I felt that for many of the years, but you know, we were a small private practice initially, which then just with the evolution of healthcare, we ultimately became part of like a bigger super group, probably about 4 or 5 years after I joined. And that was just the way everything was going. It was always the bigger is better, right? And I will say, like, it was a good move ultimately. Like we even resisted that, but you know, we were still a private practice, just a much larger private practice. But then that was kind of the stepping stone to ultimately doing a private equity deal several years later. And again, it was all in the like name of really like, we still have to get bigger and we have to grow. And so again, we're not far from Philadelphia. So there's a couple big health systems in our area that are continuing to like, of course, move out more and more into the burbs and whatnot. So we had a pretty good hold in our market share, you know, in our area. But nonetheless, the leadership of our like super group was like, well, this is our next step. And the next step being we need like a private equity, you know, partner. They're not really a partner, but we need, you know, we need to keep expanding and all of that. So to make a very long story short, there was a lot of skepticism about it, but by and large, kind of like you said, they do paint kind of a pretty picture. And I call it the best like smoke and mirrors show around because they tell you what you want to hear. And by 2022, we did this private equity deal. And so, and then within the first, 3 years, I was there for 3 years under, let's say, the private equity regime. And year one was not so bad, just not much changed really. But then year 2 and 3, it was very obvious that their goals were way different from our goals, and their values were way different from our values. Not that maybe we didn't know that ahead of time, but I think a lot of physicians are very, first of all, we're maybe a little naive. Some of us, maybe not all of us. I mean, I admit that I'm not a business or money person at all. So,
and we weren't taught to be, right?
Kind of believe what we're being told. And, I think to a point where it can obviously come to our detriment. And so, we all of a sudden we're being charged all of these like exorbitant fees that weren't, kind of really fully laid out up front, or if they were hidden in all these like,
Oh,
contractual things that maybe, although we have lawyers and accountants and all of that, like it just ended up not being the deal that we thought we signed up for, let's say.
right.
And then it
And
was,
at this point, how many partners did you have in
yeah,
that
yeah,
practice?
so we were my division, so we were still like multiple divisions within this like big super group, but the super group itself was probably about 75 docs. And then 6
Okay.
months into our acquisition, they did acquire a second smaller group that was all hand and upper extremity surgeons in our region. So then the total of the group was probably closer to 90. And then my actual division, there was 10 of us. So my division was the second largest of the super group itself. And we always prided ourselves. We were a very high quality team. We all got along. I was the only woman, but that's been the way through my whole career. So just,
That's how we roll.
yeah, exactly. But all like my brothers, like we were all like good friends and whatnot, which can be hard with a group of that many like orthopods
Mhm.
because there's a bunch of egos
Yes.
and jocks and all that. And, we all got
Opinions.
along.
Right.
Really had developed this amazing practice. And so it was very sad. It was very devastating when it was becoming brutally clear and in our faces that we were no longer in control at all of what was happening. And that was on the operational side, on the financial side, millions of dollars leaving the practice each month, to go to pay these like management fees and other, again, hidden fees coming out of the woodwork. The physicians were essentially left with the scraps. We had no control over our employees anymore. Like they were now employees of the bigger entity. And that was also really hard for us because we had many people who'd worked with us for years. And there was a lot of loyalty there. And then we started having like a revolving door of staff too. And it was just the patient experience was suffering. The operational stuff that they changed was terrible. It was clear that they didn't really care about the patient experience or the physicians. And so it just became unsustainable from a financial standpoint and just a patient care standpoint from my point of view. I mean,
Mhm.
I wasn't the only one to leave. I mean, there's a lot of guys that still stayed, and it's not like the practice has gone under yet, although there were times where we thought that was going to happen because we were in such financial like peril at times. But the company never like would never give us a reprieve on anything. They didn't really help us. The answer was always like, they needed to get their money and we just needed to work harder. And when you're already working 10, 12, 14-hour days and, doing as many cases as you possibly can in a day, like bringing charts home at night, like all the stuff that we do, and trying to do more, like you just can't.
It's unsustainable.
Yeah.
Yeah.
And
And
we
it's
were,
funny because you had the experience before of being self-owned, and you're like, "I know what it takes to
mm,
run this practice, and I understand
yeah,
how much I need to work in order to make this much money. Now I'm working twice as hard and making less money. This makes
right.
no sense."
Yeah.
I remember when our group was being looked at to get bought out as well by a bigger group, I asked specifically, "When what we get paid is based on what I make,
Hmm.
like what I do and what I produce as a surgeon, I'm essentially the product.
Right.
Mhm.
How does bringing in an extra group
Hmm.
make my product more profitable?" Like, to me, that doesn't make any sense.
Yeah.
And they, like, acted like I was so dumb for asking that question,
Hmm.
but essentially, my product is just getting chopped up into more and more pieces and getting
Yeah.
dispersed to other people, but then I have less control over my product as well, and so
Yeah.
it's frustrating. Really, medicine, I think, should be a little bit protected from, like, the business profit side, we
Yeah.
owe more to patients.
Yeah.
We do a lot of things not because it's the most profitable thing for me to do, it's because you need to get done, and we all do procedures and things that maybe we don't like to do as much or
Hmm.
don't make as much money as this other thing, but we have a duty, as community members and as people who have taken on this calling in healthcare
Right.
to do what the patient needs, and so it's frustrating when you lose that autonomy and that ability to help in that way.
Yeah. Yeah, absolutely. And so, yeah, so I mean, it was a very difficult decision, but I would have been with this practice until I retired. I would have anticipated being
Mhm.
there like 10 more years ish. I mean, I just turned 55 a couple weeks ago. So,
Dang, girl, you look good.
thanks, thanks, appreciate it. But I just couldn't. I mean, I just, from my standpoint, like I couldn't work those many hours for what I was getting paid. And I just, I was one that because I was a single mom and I was not like probably very good with investing and all of that. Like I didn't have like a big, something to fall back on from a financial standpoint too. Like I relied on my salary. So then try living on your salary, half of your salary, which is basically what it was for 2 years. And I had literally just put both of my daughters, I was finishing with my second daughter going through college. And of course they both went to, they're smart, wonderful young women and went to these super expensive private schools. And I just finished putting my second daughter through NYU. And I'm like, wow, that was a big hit, to me. And I couldn't keep working and burning the, candle at both ends or whatever you want to call it for the money I was making. I was like, I have to figure something else out. And so I leaned in really hard to like networking on LinkedIn, which I hadn't done in the past very much at all. And then that really saved me because when I left, I didn't know what I was going to do. I left without a plan. I'm like, I know I just can't do this anymore. And so I had a really like busy, kind of not great weekend on call. That was November of 2024. And I can remember that Sunday night, I've been operating on hip fractures all weekend and whatever, came home and was like, I think I just volunteered my time, based on what I'm actually going to get paid for this. So
Mhm.
like, I can't keep doing it. I just can't. So I wrote a letter. It was brewing, over the months prior to
Yeah.
that, but it was like this, that was kind of like the straw that broke the camel's back was like this call weekend. We're in a community hospital, but a busy community hospital. So our weekends were like always working all day, Saturday, Sunday in the OR and whatnot. So I was like, I can't keep doing this. And I wrote the letter. And then Monday morning, I sent off the email, and that was that. And then I was there for 6 more months and left in May of last year, May of 2025. So it's just now been a year.
Wow.
Yeah.
So you decided to leave orthopedic surgery altogether. What made that decision rather than just starting your own
Yeah.
orthopedic
Yep.
practice?
Well, a few things. So one, when I left, I was like, I know what I don't want to do. So maybe I didn't know exactly what I wanted to do, but I knew what I didn't want to do. So truth be told, right before the private equity acquisition happened, like for a year or two before that, I was kind of getting a little bit burnt out. I mean, I do love ortho. I was an athlete in the past, still an athlete with my dancing, but had ACL surgery myself, had some amazing mentors. Like, so it was all about ortho. Was a little burnout also just of the rest of the healthcare system with insurance issues and all of that, prior to private equity, and then just, got dumped on with that. So, but we had a 2-year non-compete and a very, very large geographic area. So
Hmm. How many miles was it? What was the radius?
10 miles, but we had so many locations so it wasn't just like, my division,
Mhm.
3 offices, and that's, the only spots that we worked, but the entire super group, I mean, I don't even know what the miles, I mean, that you draw it out on a map, and like I would
Mhm.
have to drive at least an hour and a half to work, probably.
Yep.
And I was like, not at this stage of my career, like not willing to do that. Like I had
Right.
lived 40 minutes away from where I worked for a long time, and that was fine. That was doable and whatever, but I didn't want to have to drive that far. I did not want to join a health system. So the health system that owned the hospital where we took call and did our work, they had to reach outside of our non-compete, and they were offering us jobs and whatnot. But I didn't want to do that and sort of exchange one corporate nightmare for another, so to speak.
Yes.
And, I'm very flattered. I got offered many jobs actually where I would have to move though, so again, like through my networking on LinkedIn and whatnot too, I met a lot of other orthopods in different areas, different states, and, felt very flattered, like, oh, come join us, come join us. And it was nice, but I'm like, I don't want to move. Like, I love where I live, and I'm a single person. So I've been single since my kids were 1 and 3. And I like
Wow.
have a social network here and
Mhm.
21 years in the community, tons of relationships, tons of patients who, know me and all of that. So I'm like, I don't want to give that up. So then I was like, well, then how do I stay and not do, like, can't do ortho here where I want to, where I want to be. So, and then I had started to look into like, what else might interest me. And, because I had just recently gone through menopause, because I am a, 50 something year old, like competitive athlete, because I was a sports medicine specialist also within ortho. So my patient population in ortho is often like, I did high school and college athletes, but I did that 40 to 60-year-old was like the mainstay of my population. And so I just was used to being in that, the adult who wants to stay active and like do their sports and whatnot. And so then I started learning more about all of it, menopause and hormone therapy, and started remembering all the hip fractures I took care of and all these ladies that were suffering. And I thought, you know what? This is very interesting.
Uh-huh.
And I'm going to dive into something new, and I'm going to stay right here. and I'm going to help people in a different way. And then I didn't know for sure if maybe after the non-compete, I'd go back and, back to ortho too and kind of do both. But the more I get into this, I just love it. And I missed the OR initially a lot, but less so as time goes by. So I really think this is like what I'm supposed to do now.
Mhm. Yeah.
I
Hmm.
think that's something people don't think about as much as maybe we should in medicine, that these non-competes sometimes are really difficult.
Hmm. Yeah.
You build a life and you come, and in your instance, you had a practice that you were all in for, not just for like 6 months and it didn't work out. You'd been there for a couple decades,
Yep.
and when it doesn't work out because of some bad business deal,
Hmm.
now you're forced to move away and leave your support system and leave
Yeah.
everything you built. Like, that's
Yeah.
so
Yeah. Or
devastating.
totally abandon your career and progression and
Yeah.
profession that you've made,
Right.
Have to
right?
start
It just doesn't make
over
any
at
sense.
some
Right.
point.
Yeah. Yeah.
It's
So,
frustrating, sad.
but I will say, like, I mean, you can, whatever little cliche phrase you want to use, like, there's find your silver lining, or, you close one door, open another. I will say that,
Mhm.
I mean, believe me, I went through my time frame of being very mad, very sad. I was devastated, like all of those things. I mean, I cried my eyes out the morning of my last day of work. I'm like, as much as I was like, okay, I need to, this is what I needed to do. And I knew it. And it was 6 months coming. I mean, I could barely get myself out of bed the last day, my final day at work, May 9th of last year. Thank goodness one of my daughters was home, and she like helped like prop me up and get me out the door. She's like,
Yeah.
gonna be okay. I was like crying my eyes out when I woke up because it was a huge, I mean, we also,
Mhm.
it's our identity, I think, I mean, yes, I was a mom. That's a big part of my identity. Ultimately became a dancer. That's another part of my identity. But I'm an orthopedic surgeon. I mean, still, like people ask me what I do. I'm like, yes, I'm a clinic owner, but I'm like, I can't not say I'm an orthopedic surgeon. Like it's just
Right.
that's what comes out. So
Yeah.
but but all that being said, people also tell me now, they're like, "Wow, like, you're, like, so excited when you talk about what you're doing and learning something new."
Mhm.
Because I mean, yes, there are advances in surgical techniques, and we're always doing our, courses in CME and whatnot, but learning something really new, it's been a while. So,
Yeah.
it was really.
And actually feeling like you're making a difference, not just patching problems,
Yeah, for sure.
right?
Absolutely. It's been really fun to like see people who are like invested in their health and want to, be proactive. And I do have it's a direct pay cash based practice. So, when people come in, we do a 90-minute initial consult. Like whoever gets 90 minutes with their patients, right? And sometimes I think their problem's a little more focused or whatever. Don't you know, every single time we are spending 90 minutes, if not more. And I tell you, people just sit down and just kind of like have a sigh of relief almost, and just, and just
Mhm.
talk. And it's great. I mean, I always like to talk to my patients before as much as I could within the confines of my 10-minute appointment slot, but this is a completely different ball game, and I do love it. Yeah, I really.
Well, it's kind of an unexpected pivot.
Mhm. Yeah.
Think of how few people in medicine have any training or comfort in, like, women's
Yes.
health, and
Yeah,
especially, like, cause care, to
absolutely.
have then someone from basically, like, the most male-dominated profession getting into
Yeah.
here. So, like, kudos to you for, getting over imposter syndrome
Yeah.
or any of that
Mhm.
to
Oh,
pivot.
for sure. Yeah, and it was there big time. And I was never so nervous as like my first couple consults here. I was like, of course I know how to talk to patients, take care of patients, formulate a plan. I, had gone through and have a certification in peptide therapy, a certification in hormone therapy, and I'm always looking to do more and learn more. And I'm involved with a peptide education platform now, and it's really cool. But yeah, those first couple of visits, I was like, oh my goodness, like I'm not sure where I'm headed, what to say. I'm not sure if I'm going to make the best plan, but they always will say too, like our patients can be our best teachers, and, really
Mhm.
like listening to people and people just feeling heard. And I'm not exclusively a women's health clinic. I see men too. It's probably a little heavy women, but it's almost balancing out. It might be like 60% women, 40% men, but certainly have a huge passion for the women's health part, having also just gone through menopause not long ago myself and dealt with a lot of symptoms there. So, and all the stuff that I saw in ortho too, that like when I start putting all the dots together now, I'm like, gosh, I wish I could have done better for some of these women that I treated. And
Right.
so being able to talk to a woman in her 40s about osteoporosis and how not to get it is so huge, and being able to talk about everything and then having people be interested in it and like being proactive about their health. I do think we're going to see some of the real experts out there who I am just in awe of, and even to many conferences and met Wanda Wright and Mary Claire Haver and all other Hirsch. And like, I'm like a disciple of theirs. I definitely have learned a ton from them, met them all in person. And, this is this movement, especially in women's health, but in general, to that health optimization or just, wellness and preventive care, I think is so huge. And I think maybe this next generation of women, hopefully there's not going to be so many hip fractures and chronic
Right.
UTIs and all of these things, let's hope.
Yeah,
Yeah.
definitely.
Let's talk a little bit about what is your practice
Mhm.
now? Like, how did you set
Yeah.
it up? How many employees do you have? And then what do you do? And can we start also with the osteoporosis thing? How do you prevent it as
Yeah.
a gal in her 40s?
Yeah. Get on estrogen.
Okay.
So yeah, so I mean, basically, I term my practice like a health optimization or quote unquote like performance medicine practice. So it is just me right now. So I am just a one woman show. I'm doing everything myself. So I think people they kind of know, like when I'm on the phone with somebody, I'll tell them that. But I think still it's always funny when they answer the phone. Like I'm like, yeah, it's Dr. Towsen. We named the clinic Towsen Clinic on purpose for my recognition of my name, here in the community. Rather, we came up with some other. So I say we because I work with a business coach.
Oh, cool.
And so that was like very intentional so that it was recognizable. And then, but people are always like, oh, and I'm like, yeah, it's actually Dr. Towsen. They're like, you're answering the phone. I'm like, yeah, I'm like, I do a little bit of everything. And they come through there's a bunch of pictures of me on the website. So even if they don't know me before, they come in and I think at the front desk, then they expect it, of course, to be someone else. And I'll stand up and introduce myself. Oh, and then like, I'll go to the door to bring them back, like still me, and then still me. I feel like I wear every hat in the clinic, and people are very gracious about it. But they're like, "This is like, they're like, this is great. Can't wait till you can expand and whatnot." So presently, it is just me in the clinic. I have a small office space that's literally in the medical office building right next door to the hospital where I worked all this time. So I stayed, right smack dab in the middle of my community. And I was very happy about that. There was a space available. It was perfect. It just needed to be kind of renovated. And so that all got started at the end of last year. And then very end of February is when I actually opened. So basically just staying in my lanes of hormone therapy for both men and women, peptide therapy, the GLP-1s. So sometimes that's in conjunction with something else, or I have some patients that are just really in the weight loss, sector. And then, I mean, I do some lifestyle counseling. Certainly, I don't claim to be a nutritionist or, I'm not like a personal trainer or anything like that. I have enough background and worked enough, with those types of folks that I think I can give reasonable suggestions. And then hopefully when I expand, I would love to include a nutritionist, include some type of a trainer or athletic trainer or somebody who can help a little bit more for those people who need to develop strength training programs. And then I have a whole team waiting to join me. I have someone from my front desk who I've worked with in the past. I have a nurse who I worked with at one of the surgery centers who wants to come. I have a PA who I want to bring with me. It's just a question of I self-funded all of this. And, when I left my practice, I was pretty screwed financially, full disclosure. So I took a big chunk of money out of my 401k, which is really crappy to do. Don't recommend it at all, but I had no other choice. And so that's what I lived on, and that's what started this clinic. So it's very like bare bones, kind of been going. And, I just studied a ton, developed some initial protocols, tweaking things as I go. But, basically it's, again, cash based. So I'm not dealing with the insurance piece. And of course, some of the things like, some hormone therapy, of course, could be insurance covered. The peptide stuff, not so much. But yeah, I'm just trying to kind of offer the whole package in that kind of health optimization space. So far, it's been very well
Yeah.
received. I've been, very lucky to have a lot of acquaintances or friends, be like my initial patients, which is very nice, and some people I've worked with before. But word's getting out now. We haven't really done like a ton of marketing. I mean, I'm on social media a lot, like more than I want to be, but it's sort of a necessary piece of it. And I don't dislike it. I'm just, trying to get better at it. And yeah, and then just the word of mouth, because again, one of the reasons I wanted to stay here so badly is because I have so many relationships and know so many people.
Mhm.
21 years in this community. I mean, you build a lot of relationships here. So far so good, and just kind of taking it as it comes, but getting busier as each week goes by, more and more initial consults coming in. So that's what I'm doing.
I
Wow.
love the pivot part of your story. I
Yeah,
actually always proud of people when they leave their initial
yeah,
job in medicine, whether it's going to a different specialty or changing their clinic in some way or going fee for service or whatever, because I
mhm,
think we put so much into our training and into developing that identity, and especially I think as a surgeon, to
mhm,
get to that point, it takes so much of you that it's really scary to drop all of that and to
Yeah.
do something else, and a lot of us will continue to punish ourselves and be absolutely miserable because this took this much time, it took this much money, it took this much of me to get here, so this is just who I am, and so I think that was so brave and is to be applauded that you were willing to just totally reframe and start again and do something else and to choose something that's, like, lighting you up and
mhm,
bringing you, hopefully, joy.
Yeah, I often think about this too because I think as a physician, and this is coming from my, like,
mhm,
little sister syndrome that I have, but I feel like physicians have an easier time pivoting because you just have so many other things at your disposal. So
mhm,
as a single degree oral surgeon,
Yeah.
mhm, mhm.
you know, I don't have an MD, and
Yeah,
so
yeah,
in the state of California, I can't do anything cosmetic. I can't do without getting an additional cosmetic writer, which they make you go through the ringer to get. And I can't do Botox as an oral and maxillofacial surgeon, but I can go to my friend who's a pediatrician or an OBGYN and they can give me Botox, you know? And I'm like, this is
yeah,
Or
so
an
bizarre.
orthopedic surgeon.
yeah,
Right. Yeah. And
yeah,
so I just think it's so bizarre, but I think about it a lot. Like, what would I do? Because you're really able to use all of your expertise and all of your experience
mm,
in order to have created this pivot with
mhm,
so much basis of knowledge.
mhm,
And you're like, now I can really apply the full picture.
yeah,
But
Yeah.
so I think, I often think, what could I do in a pivot
mhm,
that would utilize all of my knowledge, but that I would still be able to perform with my single degree dental degree?
yeah,
And it's hard, you
yeah,
know?
mhm,
It's really hard.
yeah. Yeah. No, I was like I felt like these kind of paths, did align somewhat, and I'm finding out like more and more, as I dive into this. And, part of it I think was my subspecialty within ortho as well, since I was a sports
Mhm.
surgeon. And so yeah, again, it's sort of it made sense the more that I kind of moved forward and said, okay, like what else can I do? That being said, too, I think also as a woman in ortho, I will say, like, I kind of, it was hard to sort of let it go because it is almost like a badge of honor that you wear to, like,
Yes.
go through, I was the first woman in my residency, the first one in my fellowship, first woman in my group, all of that. And so I don't know that I ever, like, I don't know, was trying to like promote that or like, that was like a big piece of it for me. However, in hindsight, like I look at that and say like, yeah, like that was like a big accomplishment. And so not that it's gone from my life. I mean, it's there, it'll always be there. But, like I always think about my kids because my kids will always say to me like, "Mom," like, because I have 2 girls, and they were like, when, people ask me what a mom does, like, we don't just say you're a doctor, we say you're a surgeon. And I'm like, and they were always like super proud of that. And so I'm like, well, what are you gonna say now? I still am a surgeon, but you could say, I guess I'm like a clinic owner. Maybe that's good, or maybe just being a doctor certainly is enough, right? But it's just interesting that distinction. They were always so proud of that. So
Yeah. I understand that. I like, you just saying it, I feel it, like, right down and deep in my soul, and
mhm.
I don't even introduce myself as an oral surgeon
Yeah,
ever, you know, that's just because I try
yeah,
so hard to make sure that it's not part of my identity,
right,
you
right,
know?
right.
So
Yeah, no, I hear you. Yeah.
So
but
can you tell us more about what it was like being a woman orthopedic surgeon? I mean, the numbers are still very low.
Mhm,
I assume 20 years ago when you were going, like you
mhm,
said, you were the first, numbers were even lower.
yeah.
I feel a tie to orthopedic women because I feel like our specialty is similar in the number. Also, maybe you're offended, but I always call myself like a oral orthopedic
Yeah.
surgeon.
I think that's great.
Like bone surgeons too. So tell us all the tea. What was it like coming up
Yeah.
and has it gotten better over time?
Mhm.
What do you think as a woman in that field?
Yeah, I mean, I think I had a pretty, like, good experience compared to some, and what I mean by that is I ended up in programs that were even though I was the first woman, they were very sort of female friendly, if you will. So, yeah, I mean, I graduated med school in 1998, so 90s. And I went to med school in Philly. It was MCP, Medical College of Pennsylvania at that time. They merged with Hahnemann while I was there, and now it's Drexel. So my like med school is went through this evolution. But when I was there, they had an affiliation with Allegheny General Hospital in Pittsburgh. So that's where I did my residency. And we could do our third and fourth year clinical rotations out there, or you could go back and forth between hospital in Philly, hospital in Pittsburgh. So there were a lot of perks to go to Pittsburgh, kind of a nicer hospital, and they gave you housing and all this stuff. So I went to
Wow.
Pittsburgh for the whole 2 years, which was huge for me because then I got like in with the guys in ortho there. And they had there was one female surgeon. She was pediatric ortho on staff at Allegheny General. So they had some exposure to, a woman in orthopedics. They just had never had any residents in their program yet. So, but I did some research and made a little name for myself with that department. And so then I ended up matching there. And so I will say I knew ahead of time a lot of the attendings. And so they were great to me. And we had a small program. It was just 2 residents a year. So I'm still really good friends with the guys that I did residency with. And I mean, it wasn't easy, but
Was that a 6-year program?
it's 5, and then
5, okay.
and then I did, a one-year fellowship, but I was newly married. For me, like, the ortho part, being the one in ortho, like, again, I had great people around me, great guys around me, and some programs I interviewed at, you could tell that they were not female friendly, for sure. So, there was definitely the bigger boys club sense or, the bro whatever mentality in some of the
Mhm.
programs where I interviewed, and there was one, I don't even know why they interviewed, but they were like, "Yeah, well, we had a female in our program once," and it was kinda, like, left at that, and I was like, "Okay, I guess that means you're not having one again, so why am I even here?" But
Yeah.
anyway, and, like, back then, probably the statistic was, like, between 5 and 6%. I mean, it's not that much more than that now, actually in practice. I mean, a higher percentage that are females coming through in residency, but it was more the strain probably that it put on my marriage, and that could be any surgical residency, not just ortho, because I was newly married, and I had 2 kids. I had both my daughters during orthopedic residency, so that
Wow.
yeah, so there's that. So yeah, so that I don't know. I mean, I don't know if there's ever a perfect time, right? So, residency, then fellowship is like so key, and then early years in practice. And then I don't know, I was really wanting to have kids younger because my parents were a little bit on the younger side. So, and it happened easily. So I felt lucky, but so that was tough to do for sure. And I think I was so scared to tell everybody, so I hid both of them for as long as I could, to be honest with you. But they were super supportive. I mean, everybody was great.
Wow.
I was very lucky to like have not really be super sick or anything, throughout my pregnancies. But I think, yeah, I'm not sure I would recommend that, or at least not 2 within 5 years of ortho residency. But I did it. But then my marriage failed. And so by the time I was a fellow, I was getting divorced. And so I had a 1-year-old and a 3-year-old. And so my parents kind of came to my rescue, and we lived as a 3-generation household.
That's
So
amazing.
yeah, but again, in my fellowship, I was lucky because one of the attendings in my fellowship was like my actual like mentor, who's the reason I went into orthopedic surgery in the first place. So I had an ACL injury playing lacrosse in college, and he was the surgeon who did my surgery. So he was one of the attendings in my fellowship. And so I was really having a kind of crappy chief year because I had just had a baby, and then my husband left 2 months later, and I didn't know what I was going to do. And so he really came to my rescue as far as like, facilitating me getting a spot in the fellowship, kind of circumventing the match and everything, truth be told, so I could be secure and move back to
Wow.
the Philadelphia area and do a fellowship under him and others. So that was great. And once again, it was just 2 fellows a year then and 4 different attendings we worked under. And they were all super supportive. I mean, even though I was the first woman, but I was with 2 little kids and going through a divorce. And I think they would have been supportive if that wasn't the case too, but they were very, very good to me. And then, I think for me, I didn't have any bad experiences. So you just get kind of used to being the only girl around. I remember going to courses or other things or just being in our conferences, and I just look around like this one thing is not like the other, but it didn't phase me after a while. So, and I know there's plenty of other stories that are some difficult times for women in ortho, and I hate to hear that, but I will say, I got pretty lucky, I guess. And I certainly think it's, a more popular choice for women. I don't think it's ever going to be hugely popular, and that's fine, but I loved it. There was nothing else I wanted to do going through med school. So, and
Do
I got
you get the comments like we do? Because people are always asking us if we're strong enough to take out teeth.
yeah. Yeah, that's fine. For
I'm
sure.
imagining, like, are you strong enough to
Yeah.
dislocate a hip, you know? Like,
Yeah.
it's about those experiences with patients.
Yeah, so for sure, ortho, without a doubt, I think certain subspecialties more so than others, but going through residency or doing general ortho or taking general ortho call, I mean, yeah, there's certain things that you definitely have to have a little bit of strength. By and large, a lot of it's though technique related and it doesn't have to be like force. I mean, the strength a lot of times comes from the size of some of our patients and like moving patients and stuff, which I would always help. And that would be always the joke. It'd be like, I was the only lady orthopod, the one who's willing to like move the patients and stuff. They're like, all your partners,
Mhm.
you can't find them anywhere when it's time to move.
Right.
All the bros when we need them.
Yeah.
Yeah.
So, but for sure, I would get some of those comments, from patients, absolutely. Even when I was like 10 years or more in practice, get the comment after talking to the patient for 15 or 20 minutes about the surgery. They're like, and you're the surgeon, or like you're the one doing the surgery. I would get that plenty of times.
Yeah.
Yeah, so there'd be that, or, I'd hear, and you think in these day and age, or even 10 years ago or 15 years ago, people are gonna like Google you, people are gonna know, like see a picture or something. I mean, truthfully, my name could be a guy's name too, although it's spelled differently. There are male Adrians, but anyway, like people would come in, I'd hear my MA, like putting him in the room, and she'd be like, okay, she'll be in, in a few minutes or whatever. And I'd hear him say, I'm seeing a woman, like, and I'd be like, how did you not know? Like, did you not see my picture on the website when you went to check? But maybe not. I guess not. So there's
Right.
still that. Or this was earlier in my career, I think, but like rounding on the weekends or something, go in, see a patient that one of my partners had done a knee replacement or whatever. And they're like, oh, are you Dr. Simmons' nurse? And I was like, no,
Mhm.
I'm Dr. Simmons' partner. But anyway, so there was certainly, a good bit of that sprinkled
Mm.
through, with patients over the years. And then there'd be the
Yeah.
patients who were like beyond thrilled to find a female orthopedic surgeon,
Mhm.
and certainly like the high school, college girls for sure, often felt more comfortable. But a lot of times it'd be like an older guy who was like, just
Mhm.
happy to have a woman, and or some women patients were like always want women doctors or whatever, and find it hard to find a female orthopedic surgeon. So
Yeah.
a lot of grateful people be like, I'm so happy to be able to see a woman doctor. So
Mhm.
yeah.
Yeah, I see that.
Mhm.
And so then in your space now, it's just really nice
Mhm.
because we often find that people come and they introduce themselves by saying they hate the dentist,
Yeah.
right? So we all have our own little quips about that.
Yeah.
And I remember going with my sister to a med spa and she had a little melia or something on her face and the gal took a needle and went and just like opened it up and my sister was so grateful to be there and I'm like, "This is insane." Like people
Yeah.
hate to come see me. They're scared of the needle, but here we are at this place
Yeah.
because it's aesthetically pleasing
Yeah.
and
He's so
they're happy
grateful
to
to
have
have
needles in
hope
their face.
in the face.
Mhm.
You know, acupuncture, they, like, let you poke them with hundreds of needles and pay
Mm.
cash.
Yeah. Yeah, for sure.
Right.
Mhm.
Right.
Yeah.
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 So osteoporosis.
It certainly is something that is, truly preventable if you start at the right time. So much of what happens with our bone metabolism and, over the years is due to loss of estrogen and a little bit testosterone as well. So, I think estrogen really is the only, let's say, medication, if you will, that's shown to be able to prevent, transition also from osteopenia to osteoporosis. So I think it's so important as soon as women start, whether they're noticing symptoms or not, but certainly if they're noticing symptoms in, their even late 30s or early 40s in perimenopause, to consider menopausal hormone therapy to some degree, because that loss of estrogen will certainly catch up with you. So that of course, in addition to strength training, weight bearing exercise, all the things that you hear about, are excellent to do. But the estrogen loss is really one of the biggest pieces of the puzzle right there. So I think it's huge. And even me personally, I mentioned I'm 55. I went through menopause probably 3 years ago, technically, and I didn't start any hormone therapy until just about a year ago. And it's because I just number one, didn't really have symptoms very much in perimenopause, had significant symptoms like when I actually hit menopause, and then was just working a ton. Private equity came in. It was like all happening. It was like the perfect storm right around that time.
Mhm.
And I just like put everything on the back burner. And I knew I was super stressed out too. And then I had some of the classic symptoms and I put on weight and all these things. And I was just like, I don't have time to deal with it. Like I'm just going to just push forward. And then when I left I not only did this whole professional reset, but I did my own health and whatnot reset for myself and, got on hormone therapy and got a trainer and got back into strength training because I was dancing. I've been dancing for 8 years, but I wasn't really doing much else. And so I was like, you know better in my mind, like, you know better.
Yeah.
And I'd done, here and there, but I wasn't doing something routinely. So I'm like, this is something you need to prioritize now. And I just went for it all. And I'm a completely different person like a year later. And it was even 6 months later, So, but I think that's the biggest piece right there is the estrogen piece. Because then, I look at every woman, nearly every woman that I treated with a hip fracture also came in with a chronic UTI, many with, some degree of dementia. And so all of that, can be, let's say, at least an attempt at prevention. And certainly, the course can be changed in a big way if we have women starting hormone therapy in their, let's say, 40s, early 40s, as long as there's no true contraindication. And for the vast majority of women, there isn't. So,
Mhm.
The
mhm,
study, the women's health study that
yeah.
got it
Mhm.
wrong,
WHI,
that's
yeah, of course.
a
Yeah.
whole generation away.
Hmm. Yeah.
It's one of the worst public health
It really is. It really is.
disease.
And there's so and I see it yeah, and I also see I see women age 60, 65 coming in now to see me, and they're like, "Yeah, my doc told me that I'm too old," which you're not, to start hormone therapy. I mean, yes, you will lose some of that protective benefit the later that you start it, but that doesn't mean that you still can't get some benefit, to maybe stabilize where you are. And then also some of these women are still having some degree of symptoms even too. And so there's a lot of information that's outdated now and whether it was
Well, we were
actually
so
wrong.
focused on the breast cancer risk, which
Right,
has been
right,
essentially shown to be negligible. In the
right,
meantime, how
right.
many hundreds of thousands of women have died from heart disease
Mhm.
or
After a fracture.
osteoporosis? And I don't think lay people, and even me, I'm just starting to kind of realize, like, osteoporosis,
Mhm.
it just like you got soft bones, big whoop.
Mm,
No, it's a killer, right? A
absolutely.
huge percentage of people will die shortly after
Mhm.
breaking the hip,
Mhm.
Yeah,
and then huge percentage of people don't ever get back to the life that they had
yeah.
before. So, this is so important for women. I got a DEXA scan for my body composition, but it didn't say anything about my bones.
Mhm.
They usually don't recommend you getting that until you're older, but is there a benefit for younger people to get a baseline DEXA just so we kinda know? It seems like, man, if I'm 30 and I see, "Ooh, it's not the best,"
Mhm.
start addressing it, or is it gonna change so much with hormones that it's not really helpful to get that information? What do you think?
I think absolutely it would be nice to have a baseline somewhere maybe in your late 30s or early 40s. And, of course, for the most part, probably insurance is not going to cover that. So it ends up being an out of pocket expense for people. And, while I don't think it's absolutely mandatory to do, certainly would be nice to see where you are. And, it may be able to if there's any concerns there or also look at what your like family history is, and of course the family history could be skewed by having, females in your family that never had opportunity or exposure to hormone therapy, but nonetheless, I think it is nice to have that baseline. Similarly with labs, but especially with the DEXA. I mean, labs during perimenopause can be not so helpful, of course, because there's, changes throughout different times of the month and whatnot. Having that baseline to work off of, I think, is a smart move. But yeah, I mean, because to your point, I'm sure you know the statistics. They're often like publicized, and like Bonda Wright does an amazing job of this. But like 70% of all hip fractures are in females, and then 50%. And I saw this. I mean, I lived this. Every weekend on call, and 50% of those women don't get back to their normal level of independence. And you see people in facilities, and then you see, of course, staffing stretched thin and whatnot. And then you see people coming back in 6 months later, breaking the other hip. And, it's just a terrible, terrible cycle. And then, again, many of these women have chronic UTIs. Many, 2/3 of the Alzheimer's patients are women. And, again, I lived it so many times of seeing people who, it's so sad. When you think about it, and while I thought it was sad at the time, it was kind of like, let me fix the hip and move on to the next one.
Yeah.
And I would have, it would always be nice if there was like an attentive family member there, which didn't happen all the time, but it happens sometimes. And then, you come in for the post-op visit and And be like, well, why did my mom break her hip? And you talk about osteoporosis and they'll be like, okay, well, what can we do about it now? And she's 85 and like, maybe not a lot, but then I was also like, well, you need to go back to your regular doc and talk about it. And is that ever going to happen? Probably not, and is anything going
Right.
to change? Probably not. And is it like, too late, which is really sad to say, but maybe. And then, there's another 30% of people who won't live, 1 year past having a hip fracture. And
Right.
so it's just, yeah, it's really a devastating injury, and then it wasn't uncommon for people to not only have, like, a hip fracture, but then maybe have, like, a vertebral body fracture or a pelvic fracture or a proximal humerus. So I was shoulder, was one of my, main joints to operate on, so I can't tell you how many times there was the combination of a hip fracture and then also a proximal humerus fracture, and then, they can't use a walker the right way. I
Oh,
mean, it's just a horrible, horrible cascade, and that's all fragility fractures. I mean, it's all, like, you know, the soft bones, and what
Yeah.
does that mean? That means your life as you knew it is over pretty much,
Yeah.
and so
right. We have a friend who is in her early 50s, and she got a scan a couple weeks ago, and she was devastated to find out, like, "Oh, no, I have bad osteoporosis," and she's usually
yeah,
pretty
yeah,
fit and stuff, but she's kinda fallen off the wagon, and so how much can you come back from that if you identify that, like, in the 50s? Like, I know doing things like jumping and weight-bearing exercise and things like
yeah.
that can help, but
Mhm.
is it enough? What do you think for that age group?
Yeah, I mean, I think, again, I would certainly add the hormone therapy at that age group. I mean, I might add, if they haven't already, a true, like, osteoporosis med, and I've seen that a couple times. I've had a couple patients who have told me, just in giving me their history, that a little bit younger, that they did, have a scan with osteoporosis and were able to reverse it back to osteopenia. I mean, I don't think we can rely on estrogen to do that alone at all, or do that at all. But I think, yes, exactly, the weight bearing exercises, but it may be worthwhile, of course, to be on some type of an osteoporosis med at that point, especially the younger that you are, and those are meds
Mhm.
that, of course, I didn't used to prescribe and don't now, but I do think that that would be a piece of the puzzle there as well. Mhm.
Sarah's having
I
anxiety
know.
attacks,
I know.
but
I'm having so much anxiety.
Whatever. I don't want that. It's
Thank you for
fun.
thank
It's
you for calling me out. I was
well,
like,
we probably have to go there, right?
I
The
know.
bisphosphonates, the
Yes.
prolias, all of
Yes, and
those.
so as oral surgeons, when you say these things, we're like,
Mhm.
"Ooh,"
Yeah.
because we see
The
the downstream
horror!
effects.
And for us
Yes.
too, I mean, then there's some, atypical fractures that occur with people on bisphosphonates, and I
Oof.
treated one of those, femur fractures within the last, like, 6 months before I left, and so, yeah, so the best possible answer is start early with your hormone
Mhm.
therapy, your strength
Yeah.
training, your weight bearing exercise for sure. I mean, and that's, so I say I have 2 daughters, they're only in their 20s, but I'm like, "You better be ready because your mother's gonna outline
Yeah.
everything that you need to do from the time you hit, like, 38 years old or whatever, and then we're gonna, protect you as best we can."
I'm
So,
so envious because I've gotten, like, no guidance at all from,
yeah,
I'm like, What
What?
did you do about this?" "I don't really know. I didn't really have any
yeah,
symptoms. I didn't really
Yeah.
do anything." And I'm like, "Not helpful.
yeah.
What
Thanks."
age are we laying down most of our skeletal development, like, prevention, like, is it our teens and 20s that we're really developing that hard skeleton, and then we just have to kinda maintain, and how do you
Yeah.
do that for your daughters? What do you recommend for that?
Well, no, I mean, I think in that age, I mean, so yes, like, teens and 20s, I mean, that's kind of when you're at your, like, peak bone mass. And then, we will start to lose a little bit over the years. But then once we hit perimenopause and menopause, then it starts to be an increased percentage year by year if, we're not doing the hormone therapy. So ahead of that, I think, obviously it's like good dietary intake too, calcium and vitamin D, that's part of it. And then it is, for sure, I think incorporating some strength training and whatnot even early. So I'm thrilled to see, my 25-year-old daughter is in the gym, and she's, doing my 23-year-old, not so much. We got to get her, corralled into, doing a little bit of weightlifting, but my 25-year-old for sure, like, she enjoys it, and so it's part of her routine already, so I think that's huge. And then, then I do think, again, by your late 30s, I mean, n nobody would exactly know when, unless they start to have, like, let's say, obvious symptoms from it, when they may truly enter perimenopause, because, we're not gonna know, until you get to that menopause day, what was 10 years before that or what was 7 years before that. But
Right.
I think, late 30s, early, like, 40ish by sure, for sure, like, is a good time to be thinking about, at least doing some menopausal hormone therapy. And again, the replacement, and even they're getting away from the term replacement, right? So it's more menopausal hormone therapy, even in perimenopause, because you're just giving low doses back, but you're giving doses that are effective and helpful on the protective side. So
Yeah.
Yeah.
that's important. Yeah. Mm.
Well, it's so important, and I think again, because we were so afraid, and people still are afraid, doctors
Yeah.
still are afraid,
Yeah.
and it's so hard. I think the message is getting out there on social media and other things that, like,
Mm,
hormones are protective for the most part, and they're really helpful for so many people, and we don't necessarily have to be afraid of it, but we've been masking with all these other things, like,
mm,
here's some calcium supplements, and here's
yeah.
Prolia bone density drug when
Right.
we could have been giving hormones and we wouldn't have to worry about your jaw
Here's a
dying,
aid, here's an antidepressant, here's all these other things when you
Right.
yeah,
right?
no, for
Yeah.
sure. Yeah, and I do. I hear it every day and on the phone conversations that I have and whatnot too. Like, I had a 42-year-old woman call me the other day, and she's like, "Yeah, I went to my doc and, he wanted to give me an antidepressant, for the symptoms I was complaining of." And she had already kind of done, her research, and she was very interested in hormone therapy, and then she brought it up, and then she was told she was too young, so despite
Yeah.
and maybe it's just because obviously I'm in this world now and like all of my feeds are, kind of filled with all this. And I'm like, how do you not know? Like, thinking to my fellow
Oh,
clinicians, like, how do you
Right.
know?
exactly.
But
A
yeah.
couple weeks ago, a specialist, and she was asking me about all these things, and I said, "Well, I wonder if it's perimenopause."
Mm,
And she's like, "No, you're too young." And I'm like, "I'm almost 43."
mm,
I said, "Isn't, like, the average menopause, like, 50 and it starts, like, 10 years before, so I'm definitely not." And she was arguing with me like, "No, you're too
yeah,
young." I'm like, "But I'm really not." And she's like, "You're
yeah,
too young." I'm like, "But
yeah.
I'm really not!"
Yeah.
Yeah.
Do
I
I
think
need to show you my rage? I can show you my
Right!
rage.
Can't you tell?
yeah,
My skin is flaky and peely every day now. Isn't that part of it? My dermatologist said it was, so it's frustrating when you have to argue with your doctor, and she's younger than me.
yeah, right.
I remember
Agreed.
giving lecture at our association meeting
Mhm.
on women's perimenopause health, like,
Yeah,
here I am as a world surgeon
yeah.
talking about perimenopause, and as I was doing the research, there's so little research in med school. Most people get
Mhm.
an hour or less, and
Right,
that includes
right.
women's
Yeah,
health specialists,
right. Exactly.
which
Yeah,
is absolutely bonkers, but the women taking care of women know nothing about this stuff either. And
Mhm.
so I was like, I met Mary Claire Haver, and I was
mhm,
teasing her like, "I'm one of the gurus like you because
yeah,
I gave one lecture, so I know more than most of the people in medicine, and I'm a dentist.
yeah,
So, hey, Dinky,
yeah,
I know more."
Yeah.
And that's really sad. Like, it should be a whole year-long course or a whole specialty or something.
Mhm.
Like, we should be devoting something
yeah,
hours and hours. This is something that most people, like 51% of the world, are gonna go through if you survive. And
exactly.
not only is it just, like, a comfort thing, but it's
Mm,
a health thing. Like, it has major health detrimental effects.
yeah,
And we don't care. Let's spend billions of
Right.
dollars on Cialis and Viagra.
right.
Yeah,
No, you're
of
right.
course.
Yeah,
So frustrating.
yeah,
So
yeah,
So where have you seen peptides fit into all of this, and how do you incorporate that into your
yeah,
practice?
yeah,
Because I'm all about this. I can't
yeah.
wait to hear about it.
Yeah, that's amazing. So, yeah, it really depends. I have like a little bit of like a clinical framework. I refer to it like a pyramid. So, peptides are certainly at the top of that pyramid, meaning they're like adjuncts, they're tools, but they're great options as long as people are willing to take them for what they are, meaning I mean, I have my, opinion and my like slant on it as someone who uses them and prescribes them and finds them to be, very helpful, despite the fact
Mhm.
that, you could have the other side, if you will, that argues, well, there for many of them, there aren't, there's not good human data, there aren't enough clinical trials, blah, 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 which, is true. I've been lucky to be involved with a platform called Truth Tides, which is this incredible peptide education platform that is really focused on compiling all of the best literature that's available. So, all the top studies that are out there, as well as anything up and coming, into a site that's very user friendly for either physicians or patients. So, you can like enter their
Oh,
site,
wow.
either a physician or a patient. And then they have all the compounds essentially. I mean, there's like not all, I mean, who has all, but like 30 of the, most commonly used or prescribed compounds, and they give them a grading system. So it's graded from like, A plus to D through the evidence that's available for them. So, so it's a very like nice, like, objective way to look. And they're only discussing, the literature that's available, the top studies, nothing questionable. And then, letting you can enter, like you can ask any questions. So even like as a patient, they get like, what does BP157 do? So you type that in and it can give you the answer. It'll give you its grade, say, it's super popular, but it gets a C plus because the evidence behind it is all animal based. And that doesn't mean that it's not useful and your evidence informed, but here's what's available. And so do with that what you want. Okay. So again, I find that, they're very helpful in certain situations. I mean, obviously I haven't been doing this for too long yet, but I really feel like they are great there's a musculoskeletal kind of category. There's sort of different categories that we've lumped them into. And so, I know you guys know, for anybody listening who doesn't know, like peptides are these little messenger molecules that many of them exist normally in our body and then they just decline with age. So that's kind of this common theme, right? So in the
Mhm.
midlife, when we're trying to optimize, we are often trying to give ourselves back things that we used to make more of and that were important for the different functions and different systems in our body. So that's really hormone therapy, kind of in a nutshell. Same with
Mhm.
peptides, many of them. The class that people know the most about, of course, would be the weight loss, GLP-1s or
Mhm.
GLP, GIP. So, semaglutide, tirzepatide. So I have an arm of that in my practice, so there are certainly people coming in who very often it's in conjunction. It's that midlife woman or guy, who has a weight loss goal because metabolism is changing, insulin sensitivity is changing in large part due to hormone changes. And so with my clinical framework, we're starting at the foundation always and reviewing everybody's kind of style. So we're always talking nutrition, exercise, strength training, sleep, stress management. That's kind of first conversation. That's why these conversations take 90 minutes, like every bit of the 90
Right.
minutes, because like we go through all of this. And even
Yeah.
some of the people that I have that are pretty dialed in, that are maybe even already have tried some peptides and whatnot before they come in, a lot of times we can still tweak something there, and find, ways to improve something on the foundational layer. And, so we always start there. And so once again, like someone who just comes in, they're like, I just want, a prescription for tesamorelin or whatever. I'm like, okay, well, hold up a little bit. Let's start from the beginning and figure it out, and see if that really makes sense. Okay. So
Mhm.
foundations. And then I think next is the hormone piece. Okay. So I mean, I've had some
Mhm.
guys come in who either have a bias against testosterone replacement for some reason. They've had like a buddy that had a bad experience or whatever it might be. And so they have a lot of symptoms that could be explained by low testosterone, but that wasn't their first goal. Like they're coming in and they're like, I want BPC 157. I want TB 500. I want, testosterone. I want, that I need to get better in the gym. I need my body composition. So they're all, also coming in with often a good amount of knowledge, sometimes correct, sometimes incorrect, sometimes
Mhm.
more like influencer type knowledge, right? So
Mhm.
it's kind of like, have to sift through that and figure out what they know and get that from them and regroup. Okay. So we look at the hormone piece though, first for men and women. And I think that's the next thing that you really do have to balance that because chances are many of the symptoms could be improved on that level. Okay. And so then if we know that that's like pretty good, or if for some reason they really just don't want to do that, like, okay, fine. But then we get to that next level. And so whether that's a GLP-1 type thing because weight loss is part of their goal, of course, those get an A plus on truth tides because they have, absolutely full on randomized clinical trials behind them, plenty of evidence that supports it in human studies. But then we talk about some of the others and we talk about like recovery and tissue repair categories. So and for me, again, as an orthopedic surgeon, the musculoskeletal complaints that people have, we will expand upon more. And so, we certainly have in menopause or in guys, who are going through, let's say, andropause or, in that midlife where they're having a lot of minor injuries at the gym or dealing with like more tendonitis or muscle issues or little injuries that seem to pop up all the time. We have a pretty significant discussion about the option of BPC 157, TB 500. There's some other blends, some other peptides that can sometimes be in blends with these two. A common one is GHK copper. So, which is a little bit more of like the beauty peptide or the aesthetic peptide, so we have that because it really works on collagen and connective tissue and, can
Mhm.
be helpful with skin, hair, nails, like that type of thing. So we really try to just zero in on their exact goals. And I'm not one who wants to also like give people a bunch of things at once. It's, a stepwise thing. So we find what their if the foundation is good, the hormone level is the layer is good, when we get there, it's like, okay, what's your top goal here? And if I have the questionnaire, like, what are your top 3 goals? And if the top goal is, better performance at the gym or improved body composition or longevity, like sometimes that's the goal, right? Like healthy aging. So then you decide, maybe if they want to dive into peptides, what's going to be the most appropriate category. And then the question is, kind of just choosing something, starting with it. There's, various protocols. I mean, with the GLP-1s, there's very specific dosing guidelines and whatnot, very easy to follow. With some of the others, not as much. I mean, there are, some protocols out there, some ways to start with dosing. I tend to be very conservative. The peptides I use the most presently are VPC 157, TB 500, sometimes together in a blend with the copper peptide. I've used a little bit of the growth hormone secretagogues, not that much, but that's also, that's another category for people that are, so I consider the BPC 157, TB 500, that's certainly more the like musculoskeletal. It's good for the GI tract as well, but more for, tissue repair, tissue recovery, the minor injuries, recovery from workouts and things like that. Then we have the growth hormone secretagogues, which, can help some in tissue repair as well, of course, but that's a little bit more body composition, reduction in visceral fat, improved sleep, and so secondary benefits could be a little bit of like cognitive clarity, executive function, things like that. So that's kind of another common category. It's tesamorelin, samorelin, ipamorelin. Then we have, you can kind of venture off into other categories, and there's like the longevity, or let's say the healthy aging. And that's where we often talk about NAD plus, which technically is not a peptide, but is often, grouped in with this discussion for, cellular turnover, DNA repair, energy, and that's been a very commonly requested one as well. So those are the ones that I've kind of used most commonly thus far. And then, there's others, of course, out there. There's lots of others, and who knows what's going to be. There's MOTS-C and for cognition, CMAX and cell length. And there's a bunch of different ones that, I've sort of dabbled in. But I think the bottom line with peptides is they are a top of the line tool, if you will. And with them, there's a certain amount of evidence available. And people need to be, informed of that and understand that, long-term studies and long-term human data doesn't exist for most of them. Yet that doesn't mean that they're, unsafe to use. It just means you have to understand that. And, the dosing, I tend to be very conservative. Like I was mentioning, some of them have, protocols and things you can follow. And some of the longevity docs that have been doing this a lot longer than me, have things that they've published in different protocols out there. And some of them, are just cycled or just used for 8 to 10 weeks at a time or 8 to 12 weeks at a time. So a lot of them aren't necessarily long-term use, or you go on it for a while, then maybe go off it for a bit, then back on it. So we could talk about this for hours, and I'm sorry. I'm like,
I know. I love it.
You guys can. I'm like, what are you even talking about? Like,
so I personally,
I'm like all in.
yeah, I personally, I take a blend called KLOW, KLOW, which is BPC 157, TB 500, GHK copper, and KPV. KPV as the least. KPV, I think, gets a D on the grading scale, and that's fine, but it's put together in this blend. And so I actually have had 2 surgeries on one knee. I have a fairly arthritic knee, which sometimes with my dancing is a little bit of an issue. Who doesn't want the copper peptides? I was like, again, I'm 55. I actually do a face cream that has the GHK and estriol in it too, which is pretty cool.
Yeah.
So anyway, but it's been very, very helpful for me. And, I'm very much into, like, I practice what I preach, and, I'm on hormone therapy, of course, as well. So I think that's also very helpful for patients. They feel a little bit more reassured to be like, look, this is what I'm on presently. Probably going to try some NAD too. I haven't done it yet, but that's something I want to do as well. And I think as long as you present it appropriately, discuss it appropriately, again, I'm involved in this education platform, and we're actually developing a CME course for physicians too. So I think that'll be super helpful. I mean, there's of course others out there and whatnot, but it would be, I don't know, it's just like kind of developing that clinical framework for yourself, I think is so key. But I'm definitely pro peptide. I think that, there's a lot of benefit there.
I agree.
Yeah.
I agree. I'm a little bit anxious about the FDA approval, because I always just feel like, I think that's a good thing, but then I also feel like then it again puts it behind a paywall that makes it inaccessible. And so just like hormone replacement therapy or, menopausal hormonal therapy, I think it's just one of those things where there has to be a better access to care and a better education system.
Right. Right. Yeah. So it's coming, I think, I hope, and and it's fun to be and exciting to be kind of part of it, just with this particular platform. So I'm very excited to see what, we can all do together moving forward.
Oh, yeah.
We make sure you add this one thing to your protocols for all of your patients that I bet you're not doing.
Hmm.
Do you know what I'm gonna say, Sarah?
Yes.
Do you wanna say it? You wanna tell her?
No, you do it.
Will you add to all of your protocols that they need to be flossing every day?
Oh yeah, absolutely, I will.
Because inflammation
Yeah.
is a huge thing, and we're spending, like, hundreds of dollars a month on peptides, and we're doing the
Yeah.
cold plunges, and we're doing all of the things,
Yeah.
yet this is, like, the cheapest, like, pennies a day,
Yeah.
takes, like, 1 minute a day,
Mhm.
and no one's doing it.
Yeah.
Like,
Yeah.
90% of adults have gingivitis, which is inflammation of their gums, and
Yep.
we're learning more and more
Mhm.
that actually has some health
Mhm.
impacts,
Yeah, sure.
We've
Huge.
absolutely
Yeah.
Mhm. I will. I would be
babe,
happy to do that.
Alzheimer's risk, all these things, it's so important, it's
Yeah.
such a easy, simple biohack, it's like the ultimate biohack, and everyone's
Yeah.
Right.
missing
And it's so easy.
Yeah.
Yeah. And it's insane because you just recognize that because our mouths are so connected, they're connected to our GI tracts, our
Mhm.
faces are so vascular, our
Yeah.
mouths are so vascular. And when you have this just sort of subacute, subclinical inflammation always, and then you go and brush your teeth or you bite into an apple or you bite into a steak or a piece of bread, you're
Yeah.
introducing all of that into your bloodstream, and every day you're just swallowing it,
Yeah.
right? And so you're expecting your body to be optimized when you
Yeah.
can't.
Yeah. Yeah. So, yes. Yes, ma'am. I sure will, because 'cause you're right. I mean, I don't talk about it now, but we'll add that in there.
Yeah, that should be on every
Mhm.
post-op
Yeah.
paperwork.
Yeah.
You
Mhm.
can thank us, we can call, like, the Sheffield Harding protocol
Yeah.
thing.
All right. Will do.
Yeah, the resting stitch face protocol.
I love
Yeah,
it.
We
it's good.
invented it, yeah,
Mhm.
exactly.
Yeah.
Yeah. Is there anything else that you wanted to share with our audience? I think they're gonna find this incredibly helpful and enlightening, and I love
Yeah.
all of your story. Like,
Aw,
it's just
thanks.
empowering and
Yeah.
really cool.
Thank you.
And I know that it was hard, so we appreciate you going through it and
Yeah.
showing us that it can be possible.
I mean, I think that's just the biggest thing. I think that it's never too late to do something new, to reinvent yourself, whether that's professionally, whether it's personally. I mean, again, I took up ballroom dancing at 46, which everybody always assumes I was dancing since I was a kid, and I wasn't. So I think I've done it a couple of times over now, and I just think that it's something that could be a little bit scary or challenging, but the reward is huge. So it's really never too late. Midlife is such an amazing time because I think you have a good bit of experience and wisdom, and I'm really enjoying after a pretty shitty year, this it's so much better now, and I could have never imagined. And it's just like forge ahead, take some risks, do some things you didn't think you were going to do, and see how it goes. It's likely to
Oh,
work
yeah.
out pretty well. Yeah.
Darling.
I
Yeah.
love it. Well, how can people find you if they're looking for you?
Yeah, sure. So I'm most active on LinkedIn. So it's just my name as my profile on LinkedIn, but my clinic or my name, just Adrienne Towsen, MD. I'm on all the other platforms now. So, content
Cool.
creation has become huge. So even I'm on TikTok, Instagram, Facebook. So you can find me by my name on any of those. And then the Towsen Clinic is my clinic, and it's just the website is towsenclinic.com.
Great.
Awesome.
Yeah.
Well, thank you so much. This has been really wonderful chatting with you, and I'm just so glad that we got connected.
Yeah, me too. Thanks so much for
So
having me.
cool. Yeah, for sure. All right. Well, thank you again.
Yeah, thanks for joining us for another episode of the Resting Stitch Face podcast. As always, please like, share, and follow. Until next time.
Bye.